Well, as we understand that left main bifurcation stenosis accounts for almost two-thirds of all our cases of left main disease. And it is always a challenge to treat left main bifurcation stenosis with bifurcation stenting. We know that if there is a mishap on the CAT table, for sure the patient is going to land into serious consequences, including mortality. The results are influenced, as said previously by the various speakers, whether the left main bifurcation stenosis is simple or complex according to the definition criteria. Well, the experience and expertise of the operator is an important ingredient in treating left main bifurcation stenosis. But something which has been overlooked is the left main bifurcation angle. So let me concentrate on the left main bifurcation angle today. Well, when we look at an angiogram of a patient with left main bifurcation stenosis, one must realize that all left main bifurcation stenosis are not the same. Here is an example of a patient with short left main, ostial LAD, LCX and ramus, and a shallow bifurcation angle. And in contrast to this, we have another patient with a wide bifurcation angle between the LAD and LCX. And thirdly, we have yet another patient with a long left main with a tight LAD stenosis and a bifurcation angle which is almost about 80 to 90 degrees. So here, every patient is going to be treated differently. But before we go on to discuss about the left main bifurcation angle, it is important for us to understand how do we assess the left main bifurcation angle. Well, there are several techniques, and one of the most commonly used techniques in our lab is simply coronary angiography. But when we do angiography and are trying to look at the left main bifurcation angle, one should take an angiographic view which clearly shows a separation between the two main branches, the LAD and circumflex, and a view which does not foreshorten any of these two major vessels, and the best view is possibly aleocaudal. And in this view, we go on to look at the three different angles. Angle between the left main and the circumflex, which is called often the angle A. Then between the LAD and circumflex, which is called the angle B, and the angle C is between the left main and the LAD. However, the importance of these three angles may vary differently in the hands of the different operators. There are different studies, conflicting data. But most often the angle which is used to decide about the strategy is the angle B, which is between the LAD and circumflex. The other technique is a three-dimensional QCA. We do a 3D reconstruction of the coronary tree from the two orthogonal views. Well, certainly it is more accurate, more sensitive, reproducible. And in 3D reconstruction, we look at two angles, the left main and left circumflex angle, which is called the proximal angle, and then an angle between the LAD and LCX, which is again the distal angle. The third, there is a study which is a sub-study from the Syntax trial, which has made some observations on these angles. And this study has shown that there is a movement of these angles, change in these angles with the systole and diastole. And they clearly said that during systole, there is an increase in the proximal bifurcation angle, and there is a decrease in the distal bifurcation angle. And second observation which was made was that after PCI, the bifurcation angle decreases in systole and also in diastole. So these two are important observations which have been made out of 354 patients when they looked at the sub-study of the Syntax trial. The third way to look at the bifurcation angle is a computerized tomography or the computerized coronary tomography. And again, we look at the same angles as I said earlier. And again, they said that the possibly most important angle is between the LAD and LCX, which is also a predictor of the stenosis. A wide angle between the LAD and LCX is related to a non-calcific plaque and often a stenosis in the. And lastly, we have got the OCT, which is a newer technique to look at the left main bifurcation angle. We take a longitudinal view and we mark the distal reference point and then see the side branch, calculate the side branch angle, calculate the carina tip angle and also the length between the proximal bifurcation point and the carina tip. All these are important measurements which are done on a longitudinal view of the. Now, the second question is left main bifurcation angle a predictor of significant coronary stenosis? Let's look at the answer. Well, there is a study on 160 patients using both coronary angiography as well as CT angiography, and they classified their patients into those having a significant stenosis in the LAD or circumflex, and significant stenosis was defined as 70 to 100%, and insignificant stenosis less than 50%. And they found that patients who had significant stenosis, their LAD LCX angle, that is angle B, was much wider, 80 degree as compared to those who had insignificant disease. The other angles, that is between LMCA and LAD and LMCA and LCX, were not significantly different between the two groups of patients. So they concluded that the bifurcation angle between LAD and circumflex is an independent predictor of significant coronary stenosis. Well, another study showed that a wide angle was more often associated with the presence of left main bifurcation disease as compared to a narrow angle. These patients who had a wider angle were often males. They had a higher body mass index, and their plaques were more often non-calcific as compared to those who had a narrow angle. Then what is the significance of left main bifurcation angle in selection of the two stent techniques for bifurcation stenting? Well, EBC has classified the bifurcation angle into two types, the T stenting and the Y-shaped stenting, Y-shaped bifurcation and the T-shaped bifurcation angle. Well, Y-shaped bifurcation angle, as we know, is less than 70, but it's not a suitable case for T-stenting because of the geographical miss, or you can either inadvertently protrude the side branch stent into the main vessel, both of which are not advisable. A crush or culotte technique is more suitable for Y-shaped bifurcation angle, and it gives a better coverage of elliptical ostium. In contrast to this, they said the second type of angle is a T-shaped angle, where the bifurcation angle is more than 70 degree. And T-stenting is ideal when side branch stenting is done appropriately in these cases. However, there is a limitation of T-stenting in these cases because of incomplete stent apposition on the carina side, as you can see here, a carina side of the bifurcation due to inadequate stent expansion at the side branch ostium. Then the OCT gives us certain important predictors of side branch occlusion, and one of them is a side branch angle. And it has been shown almost about 8 years ago by Watanabe et al. That in narrow bifurcation angle, which in this case has been shown as the alpha angle, is a predictor of side branch stenosis besides the narrow carina tip angle, the diameter of side branch orifice, and the length of the proximal branching point and the carina tip. Now, lastly, look at is there any impact of left main bifurcation angle on the long-term clinical outcome in these patients? Well, the reports are very controversial, so I think I will not be able to give you a final judgment on this. But you see here the two angiograms where the upper one is showing a very narrow bifurcation angle, whereas the lower one is possibly showing a wider bifurcation angle. Now, there are studies which have shown a significant effect. There are 4 studies, and overall these 4 studies have included almost about 1,900 patients. Assessment of the angle was done by QCA, either 2 or 3D QCA, and the stenting technique was two stent technique in most of these studies, and the follow-up was ranging from 11 to 36 months. Well, these studies derived certain inferences. One is the LMCA to LAD angle is, if it is more than 150 degree, then it is an independent predictor of target lesion failure after crushed stenting. Whereas there is no influence of this angle on the T stenting. So the wider angle between LMCA and LAD is a predictor of a bad outcome. Then LMBA to the angle between LAD and LCX, if it is more than 70 degree, then there is a higher restenosis rate if 2 stenting technique is done as compared to 1 stent or as provisional stenting is done. 35% versus 14%. And lastly, there is a change in bifurcation angle between LAD and LCX of more than 7 degree, between systole and diastolic, what is called as the dynamicity of the angle. This is associated with higher TLF versus a smaller change, which means less dynamic bifurcation angle. Now, the sub-study of the syntax trial also looked at the bifurcation angle of three different tertiles, less than 80 degree, or between 80 to 106 degree, and more than 107 degree, and they did not find any significant difference in the maze at 5 years. So they concluded that there is no significant effect of this bifurcation angle on the maze at 5 years. But they came out with another variable, which they defined it as a post-PCI systolic diastolic range, what they have been calling it as, again, a dynamicity of the bifurcation angle. And in this sub-study of 110 patients where they had used a two-stent bifurcation stenting technique, the post-PCI systolic diastolic range was defined as an absolute difference between the diastolic and the systolic distal bifurcation angle. And they said that the maze rates were significantly higher, 52%, if the post-PCI systolic diastolic range was less than 10 degree. So this was an important predictor of maze. So what they concluded that it is not the static angle, but it is the dynamicity of the angle, particularly after PCI. And if the angle change is less than 10 degree, then there is a higher rate of major adverse cardiac events. Now, then there is a multicentric registry from 4 different centers of Korea. I'll not go into the detail, where majority have used a two-stent technique. And they also came out with almost similar. There is a significantly higher TLF if the angle is more than 150 degree between left main to LED, and there is no significant difference of T-stenting. Crushed or T-stenting, there is no significant impacts. So let me show you 2 cases out of my 700 odd cases of left main bifurcation. I'll just take 30 seconds. Now, this is just an anecdotal case. Do not drive any conclusion. Here is a patient who had a very highly calcified left main bifurcation stenosis. And you can see a very wide angle between the LAD and LCX. And this patient underwent a very successful stenting using a tap technique. And you see after 8 months, he came back with a high-grade restenosis. So wider angle restenosis rate. In contrast to this, I am going to show you another case. Now here is a case with a very narrow angle with a left main bifurcation stenosis. And this patient also underwent a decay crush technique, excellent result. And 4 years down the lane, patient had no symptoms. He was subjected to angiogram and was found to have a stenosis, new stenosis in the right coronary artery. So this is just an anecdotal example that a wide angle between the LAD and LCX was associated more often with a higher target lesion failure as compared to a narrow angle. So what is my take? Well, LAD-LCX angle of more than 150 degree or a wide angle is most important angle for deciding, sorry, the LAD-LCX angle is the most important angle for deciding the two-stent strategy for PCI. Other angles may not be very important. Crush technique is preferred for LAD-LCX angle of less than 70 and T or TAP for more than 70. But there are controversial reports on the impact of left main bifurcation angle on long-term clinical outcomes regardless of the technique. Possibly, I feel there is no significant impact of left main bifurcation angle provided PCI is performed appropriately and selection of a more suitable two-stent technique is carried out for the case that is in question. However, we need randomized trials to compare decay crush with others on the basis of left main bifurcation angle. Thank you very much.